All right, let's talk about the transfusion-related acute lung injury, commonly called trolley. Okay, so for the trolley in general, and that's kind of how I'll refer to it here, it's another one of those situations where we're looking for something really particular to kind of call our attention to this disease process. So let's just kind of go through it really quick, and then I'll circle back and kind of tell you what to look for. The concept here is, remember, if you have a patient, for example, that you start on some steroids, you are very frequently going to see an elevation in their white blood cell count in the blood, in the serum, right? And the reason for that is because you've now activated some of the neutrophils that are going to be residing in the lungs, where you're going to have quite a bit of your neutrophils in the pulmonary vasculature. Just think of it, again, we're using simple terms here. Just think of them hanging out essentially. What we're doing is we're activating pulmonary endothelium that's causing neutrophil sequestration into the blood, priming and activating these neutrophils. And again, when these neutrophils get activated, we're going to have pro-inflammatory cytokine release. What is causing this whole process to happen? The actual pathophysiology, there's a lot of different articles and that kind of thing on it. For step one purposes, the thing that you have to know is that there are certain risk factors that patients can have for trolley, but again, most of the pathophysiology is beyond the scope of step one. The thing that you have to do for trolley is know that you have neutrophils that are primed in the pulmonary vasculature with activation of the pulmonary endothelium, and you have to know that these neutrophils are going to start to release a lot of those pro-inflammatory cytokines that we just talked about with febrile non-hemolytic reactions. And those cytokines being released, and if you think about where they're being released, a lot of these are going to be released in the lungs. So if I kind of go, take a snapshot here, way deep into the lung parenchyma here, I'm just going to take some pulmonary blood vessel here. Okay, so I have some blood vessel running here, and then I'm going to have all of these neutrophils that are going to have released all of these cytokines into the pulmonary vessel. And these cytokines, right, they're acute inflammatory cytokines, they're going to cause me to have vasodilation of these pulmonary vessels. And when I vasodilate these pulmonary vessels, remember, I have my endothelium kind of sitting here on the surface. And as I vasodilate, I'm going to start to get some gaps here, right, into this endothelium. And so what's going to happen? Well, a lot of the fluid is going to move through those endothelial cells and make its way into the interstitium. And so I'm going to get interstitial edema, right? Interstitial edema from the dilation of those pulmonary vessels and the increase in vascular permeability that's going to occur in the setting of this pro-inflammatory response, which is actually very similar to something that we'll talk about in the pulmonary videos, but that's going to be ARDS, right? We're going to have a very similar presentation to what we're talking about here, and I don't want to go into too much detail on that. But you can imagine, like I said, you'll have interstitial edema, right? Pulmonary edema that's non-cardiogenic in nature. What does that mean? Well, that means it's not originating from the heart. It's not like the pump is broken and things are backing up into the lungs, like we talked about quite frequently with heart failure, right, in the cardiology section. That's not what's happening here. What's happening here is almost like a tip over the edge in terms of pro-inflammatory response that's now causing this widespread increase in pulmonary vascular permeability, dilation, etc. Now, again, non-specific on the timeline, right? Could be during or hours after the transfusion, but what is the presentation? That's the key here. Remember, there's always something that you have to kind of tease out of the question that's going to distinguish it from the others. And the key here is that these patients will be very short of breath. They might have increasing oxygen requirements, right? They become tachypnic, for example. And the classic vignette is going to be a patient that's receiving fresh frozen plasma or a platelet transfusion. Okay, so again, the other situations we talked about, a lot of them were referring directly to red blood cells. We're not saying that you can't have this happen with a red blood cell transfusion, but again, what's the classic vignette? What are the things I'm looking for? Shortness of breath, increasing oxygen requirements, interstitial edema, right? And you can also see that here on the chest x-ray. You can see all of this haze in the lung fields, and the patient will classically have received fresh frozen plasma or a platelet transfusion. Okay, we already said interstitial infiltrates on the chest x-ray. Key here is that it's transient, and a lot of these will resolve spontaneously. And so you can see here, this was the initial chest x-ray of this patient here that had trolley, right? So you can see kind of this haziness throughout the lung field. And then you can see the repeat chest x-ray here, right? This is largely resolved. We don't have to go into all the details on reading the chest x-rays and that kind of thing. This is going to be an option along with things like a febrile non-hemolytic reaction, or they might be teasing this out versus like a cardiac cause, for example. But again, classically, fresh frozen plasma, platelet transfusion is very classic. And then remember your pathophysiology. Pro-inflammatory cytokine release largely driven by priming and activation of neutrophils. Again, do you expect there to be a positive Coombs test? Not really, right? Because the whole concept with the Coombs test is we have an antibody that's binding usually to a red blood cell that's targeting it for destruction. There's really no red blood cell hemolysis here, so we wouldn't expect these to be elevated either. Again, if you understand the pathophysiology, they can throw lab values at you all day. You don't have to memorize these. You just have to think about it, right? You have to think about, what is the lab value telling me? Is that something that's happening in this disease process, right? So again, the key is if it's happening during the transfusion, like we said, we stop the transfusion. And because the patients largely are having some almost like an acute episode episode of respiratory distress, we're going to provide respiratory support. That's going to be the key, but usually will resolve spontaneously.